How's that? That work for
Sure.
you guys? You see
Perfect.
the, okay.
Yep. Yep.
All right. So we're going to talk, you know, we always, everybody thinks of buprenorphine as that medication that we used to need our data waiver for, right? The X waiver, and do I need to have that and what have you? But we're going to be talking, I'm going to be talking about buprenorphine really exclusive of OUD today, and try to see if I can get you to think about this molecule a little bit differently in a way that is more beneficial for a wider variety of patients. So, the question is what I think we see a lot of the time is people are thinking about, now that they're marketing the branded versions of the lower dose buprenorphine, we see that people are thinking about it for those patients that, could I try a little Butrans patch instead of a bit of tramadol or hydrocodone or something? And what's the plus minus of that? It can be expensive, the branded versions and what have you. So we're aware. I've got the kind of practice where people have been on medications for a long time and they only come to me because they're failing, obviously. And so I can tell people are thinking about buprenorphine and they're trying to work it in with their regimen. They're understanding some of the benefits, and the interesting part about it is that it can do different things than people think. I guess is how I would say that. So I'm going to just show you a few studies that kind of talk about why buprenorphine, I guess is the best way to say this. And so this is a study that's not new. It's 10 years ago, and it really, I think, opened up a lot of eyes. It's not a big study, but it was really dramatic. And essentially what this study said is, let's find people who are failing high-dose opioids. These are people that had pain scores between 7 and 8 out of 10, despite a significant mean MME in these patients. Of all the patients in this study, they ranged somewhere between 200 and I think like 1,300 MME, kind of numbers that we really don't see anymore. And these patients were continuing to describe significant problems with ongoing pain, and so they were switched into buprenorphine, and it was, I think, probably at the time we would do that 10 years ago, we would be doing this simply for safety, right? And we weren't sure what the symptoms of that would be that would reproduce. But lo and behold, what they found was not only did these people have a 50% pain reduction with respect to their self-measurement of their pain, and these are chronic non-cancer pain patients, but they also had a measurable increase in quality of life measures. And so this opened our eyes. It wasn't a large study and it wasn't a prospective study or blinded or what have you, but something else was going on here than what we thought of for this molecule. And the other part about this, and I would say this is something that's absolutely seen in our clinic, and I think a lot of people who are familiar with it for pain would say, is that patients prefer this. Almost all of our patients, they're very skeptical about the switch at first. We have to be careful about how we switch them over, but to a T, we're so accustomed to these people coming back a little bit later saying, wow, do I feel better? How much better can I feel from this? And I think it's really enlightening to us about what's happening with this molecule, and where we're getting to. Another study uh, tried to look at, well, what's the efficacy based on the dosing range, right? There's a wide variety of chronic opioid management patients and what different clinicians think is acceptable. We know what the CDC says about the 90 MME and possibly 60 MME and what have you, but these are individuals that were switched, and what they found was not only when you switch individuals, I'll show you this study, what you see is across all baseline MME numbers, you get the same reduction in overall pain scores that individuals with chronic non-cancer pain feel. So people, again, they're talking about scores of 7 or 8 out of 10 prior to initiation, and these are people whether they're on more than 200 MME or less than 90. You switch them over, and what they get after conversion is a 50% reduction in pain that we can measure. And everyone kind of says, okay, 50% better. Yeah, how good is that? I always want to remind people that when we look at studies for the benefits of legacy opioids for chronic pain, it's illusory. We do not see benefit. I can show you there's an Annals of Internal Medicine meta-analysis that tells us that chronic low back pain, benign low back pain managed with opioids is worse than no treatment at all. As when we really measure what the effects are. Now, individuals don't tell us that on a one-by-one basis, right? Because they're caught up in the, when I take it, I feel better, and when I don't, I feel worse. But when you measure populations that are managed with opioids, you cannot show a benefit with opioids in chronic pain. But here with buprenorphine therapy, you do find a benefit. You can show what a 50% reduction, a 50% reduction in pain in a chronic pain population is as robust as anything, right? That's better than pregabalin for neuropathy. That's a very substantial number, and I'll show you some other benefits as we go forward. But I think this is really eye-opening data. And again, on this study, once again, not just low dose people. These are not low dose opioid management patients. They're not coming in on 3 hydrocodone a day. They're on high dose opioids. And interestingly, when we really looked at the data, the very, very highest MME were the patients who did the best. And half of this population was more than 200 MME. What this does, and I think where we need to think about this is that missing link with respect to the 2 CDC guidelines recommendations that came out, right? 2017, the CDC guidelines said, hey, maybe we shouldn't be mixing sleep aids with benzodiazepines, with muscle relaxants, with opioids. But it also said, if you're going above 60 MME, you're probably going to fail. So think twice before you do that. And definitely think twice before you go up to 90 MME, right? That's what came out in 2017. And then that was revised in 2022, I believe, because what happened was all the insurance companies said, you got to cut your patient off. You got to stop prescribing for your patients if they're above 90. We don't cover MME numbers like this. So you would get really roundly criticized, and you would get those notes saying, well, we're going to expect you to wean your patient off because you're outside of CDC guidelines. In 2022, the information was clear that this was a fatal mistake for a number of patients. And not only was it wrong to force taper individuals, but we could measure worsening, morbidity and mortality when that was happening. So it was a measurable effect. So the CDC came out in 2022, said, really stop it. Do not force people to wean off in legacy opioids. So now you're a damned if you do, damned if you don't situation, right? As clinicians, and we're thinking, all right, how do we manage this patient? I can't manage chronic pain patients because and how many times do we have somebody show up at our doorstep for the very first time and they're already on medications that we think are counterproductive? And now what do? I want people to really kind of get the idea that this is where we can fit this in, because this is not deprescribing. Quite clearly, what we're doing, we're switching to an agent that works while it's safer, right? Once again, showing the extreme levels in additional study, pain before and after with MME equivalent, 1,000 MMEs. We don't see MME patients like this very often. This was a VA study, and it showed very, very high MME numbers, and yet they were still able to demonstrate a very robust reduction in pain scores with switching into buprenorphine for chronic pain. I would tell you that each of these studies I've shown you so far, in order to be in the study, opioid use disorder had to be excluded. So these are not individuals that have opioid use disorder, and that's why they're being switched over. They've been managed presumably for chronic pain. The trick is how, right? And that's the challenge. And so Lynn Webster, who's a really well-known pain physician, and he's been in Salt Lake for a long time, and some other people from Stanford and elsewhere came up with a consensus statement some time ago interesting thing about Lynn Webster is that he is originally a graduate of Oakland High School in Nebraska. So some of us have heard of him before he got famous and went off to the West Coast. But he convened an expert panel to talk about how do you use buprenorphine in chronic pain, and when to consider it, and why is it working, kind of going through that to help clinicians in a practical way. And I think lost in all of this is kind of the history of buprenorphine, because what people don't generally think about is that buprenorphine was not the medicine that was initially intended to be used for opioid use disorder. It was discovered in the 60s, and they were looking for an analgesic agent, and it was first not even launched as an oral or a sublingual agent, but for use IV. And and then what happened is, for a while that it was classified as a C2, because we didn't understand. I don't think they understood the overall effects with respect to respiratory suppression and the limits on that. Hold on, I gotta quiet my staff down. So then 2000 came out, and that's when office-based opioid treatment came out, and it was determined that this would be a very effective way to manage patients with opioid use disorder. And so the DEA at the time, I think most of us feel this was pretty misguided policy, but they came up with this data waiver that you need, and the idea that you have to have that special X waiver in order to prescribe this. And so, to this day, I think we have a very distorted view of the efficacy and or safety of buprenorphine. I can't tell you how many times I have a patient come back to me who they come to me and they're maybe on very high dose oxycodone, and they've got their Narcan, and we talk them into switching into buprenorphine, and they go to the pharmacy, and the pharmacy tech slides it across the buprenorphine across the table and says, this is a very dangerous medication. You have to be careful with this. And they come back with a box and they won't use it because now they've been given the fear of this because it's unfamiliar. And there's this vague idea of if I'm on buprenorphine, what happened, and all of that. We'll talk about that a little bit more, but fundamentally, this all changed in the last year when the DEA, along with a bunch of other things, said, hey, let's maybe get rid of the data waiver, essentially in order to get more people to treat opioid use disorder with buprenorphine. And in exchange, what they ask for is that eight hours of training, which probably brings you all here to these meetings. We understand that, but fundamentally, I think what they're hoping that we do is communicate how to manage these groups of patients a little bit differently. And so that's where we are today, and that's why there's all this interest in buprenorphine. But what does it mean? What's the genesis of this? We know it's a partial agonist, right? And this is in the Webster study. Partial agonist has nothing to do with partial efficacy. All right, a full-on we've seen that. I hope I've convinced you that full agonists don't provide relief in this combination, in this group of patients that we think they do. So why would a partial agonist do that? And it doesn't have any correlation with analgesic potency, right? Potency, we know, is the microgram. It's the microgram to milligram dosing of the agent. We know buprenorphine is very highly potent, but very importantly, it's very tightly bound to the receptor. It hangs onto the receptor in a fundamental way, and what that does then is it allows for sustained response, and therefore its half-life of 35 hours provides benefit, while the affinity of the molecule staying on that receptor gives you the long-acting effect. The other part, the one thing that we do see, however, with buprenorphine in terms of its tolerability, is that the partial agonist effect does affect which of the opioid receptors that it's interacting with, and it's an agonist for. And in that way, what it doesn't do is it doesn't have the kappa effects and the dynorphin effects, which lead to those sort of lack of tolerance at higher doses and the kind of development of problematic use patterns that can develop. It's just not interacting with, it's interacting differently with the receptor, and what it is interacting with probably is more the mu activity, which is why it's got better intrinsic activity than we would expect, given the fact that it's a partial agonist. So we really have to overcome the misperceptions of buprenorphine as a partially effective opioid rather than a fully effective opioid. And we do have studies that demonstrate this. And one of the ones that really I think is most interesting is, one of the worst things you see is, as an acute, this really hurts kind of a problem is kidney stones, right? And so they did a study and they showed that sublingual buprenorphine was more effective than IV morphine in individuals who are undergoing renal colic. And that is efficacy that's pretty hard to refute. And there are in studies with acute pain models, we see greater analgesic efficacy to morphine, fentanyl, even some of the super potent morphine analogs, sufentanil and what have you. It's just simply more potent than we think. And so that probably, I don't know that we fully understand that when we talk about the receptors and the population of receptors and what have you, but one thing to think about is that therapeutic index, right? Because therapeutic index is defined as where is the molecule effective between when it starts to work and when you can't take it anymore. And we don't know for any given legacy opioid exactly where we're going to get respiratory depression in any individual. That's always a challenge. Obviously, individuals become habituated with their particular opioid of choice, but at some level, every legacy opioid is going to give respiratory depression in a dose-dependent fashion, right? You're going to slow your breathing rate down. You're going to be less responsive to the buildup of CO2 and what have you. So you will get respiratory depression, and that is the top of the therapeutic index, right? So wherever you were starting to get efficacy and where you were getting respiratory depression effects, in between there is where you're going to get that. And since there's really kind of no top limit, that buprenorphine respiratory depression line will continue to flatten as we go up. It does not ever increase. It doesn't go beyond a certain point. Even with attempts at intentional overdoses, we really rarely see, unless it's being mixed with other molecules that potentiate it, it's very challenging to get respiratory depression with buprenorphine. Therefore, you have a wider therapeutic index in individuals, and that's particularly important in individuals who have been chronically exposed to opioids. Other factors that are helpful is that I always have to look up the buprenorphine metabolic pathway. I think it's the well, I got a CYP-A340 part of the P450, and it's basically glucuronidation after end dealkylation. So it's excreted in the bile like opioids are, but its pathway is very common. And so what we don't typically see are rapid metabolizers, which of course are the worries and why we think some of these individuals get into trouble more quickly than others. It's very low incidence of interaction, drug-drug interaction, and therefore it's really from a standpoint of, do we have to worry about other medications? It gives us a lot of freedom. We see this in individuals, they don't come in, right? They don't come in just on opioids that aren't working. They come in on muscle relaxants that aren't working, and somebody's not been able to wean them off of maybe a clonazepam for muscle relaxation, or maybe they're taking Z drugs at nighttime because they can't sleep with their chronic pain. Now, all of those other agents are less worrisome to us as we think about an order in which we straighten out their medication profile, if we can get away from the synergistic effect of the legacy opioids. And when that really helps us a lot, quite obviously, is individuals with increased BMI, history of sleep apnea, and comorbid psych disorders. I have to confess, I don't fully understand the antidepressant effect of buprenorphine. Listen, Dr. Stoll talks about that, and I do believe that we're getting kind of increasing evidence that shows because of some effect of the buprenorphine, there is some beneficial effect on mood disorders that's independent of its analgesic efficacy. It's not something I can really, yeah. So the next part of this study with Webster and all was talking about, okay, so hopefully I can convince you that it's a benefit to patients, right? I think people understand that it can be helpful. The trick is now how, how does it work? Isn't it hard? And this challenge comes to us probably also because of all of the extra work required to get your data waiver in terms of switching individuals over from who come into our door with opioid use disorder, and we go through that period of withdrawal and we have that discussion, we have to get them to comply. And that has implications, right? We think about switching back and forth between legacy opioids and buprenorphine. And I think that there's been a lot of consternation about that, which probably is overwrought. Fundamentally, you can almost all of the time, if you've got an individual at 60 MME or maybe even 90 MME or fewer, you can do a direct conversion. And I'd say that again, you can do a direct conversion from legacy opioids into buprenorphine therapy. And this article that I showed you with those guys specifically kind of talked about just have the patients go to bed overnight, have them go to bed overnight without their opioids, wake up in the morning and initiate buprenorphine. We'll get into a little bit more about that. I'll talk about that more next week because there's lots of nuances about how to do that. And if you do it too quickly or too slowly, you're going to have unnecessary kind of bumps in the way for patients. But when you think about it, what's interesting, when you're thinking about why buprenorphine can be converted over and how, under what circumstances it's effective and how you do it, understanding the concept that buprenorphine is very tightly bound to the opioid receptor and it has a half-life of 35 hours. So it's bringing itself up very slowly. And when you've got an individual with legacy opioids, their half-life is very short, even if they're on something like OxyContin, right? There's continual association and disassociation from the receptor. And fundamentally what happens is when you start buprenorphine, since it's got that low and slow benefit, what it does is it doesn't go into the receptor when the other opioid is on, but as soon as that dissociates, it sneaks in and then it doesn't let go. So it brings itself into the receptor, and then now that receptor is no longer available to the legacy opioid. So when you think about that going on at doses that are meaningful clinically, if you've got 2 milligrams of buprenorphine sublingual, so in 24 hours you're giving 2 milligrams, then what happens is 60% of the mu receptors are still available, all right? If you're even at high dose, 16 milligrams of buprenorphine, this is the dosing that we use for opioid use disorder, you still have 20% of opioid receptors that are available, all right? This has implications for perioperative management that I want to talk about, but even at very high doses, it's not easy to get authorization for 32 milligrams of buprenorphine sublingual for an individual that you're treating for use disorder, for substance use disorder. You still have almost 20% of the opioid receptors available, all right? So the interesting part about this is, generally speaking, it's generally below 4 milligrams and really probably 2 milligrams and lower a day that we're using buprenorphine for analgesic efficacy. All right. If I've got somebody who's on 90 milligrams a day of OxyContin or something like that, their translational dose will probably be not more than 2 milligrams of buprenorphine. That has some implications, and part of the challenge is the formulations of buprenorphine that are generic, that have been around for decades, are I've not seen one lower than 2 milligrams. And so we have to kind of work through that a little bit. And these companies, Belbuca and Butrans in particular, they're making a lot of hay out of the fact that they've got microgram dosing, right? And microgram dosing is efficacious. And we have a way to get around that I think is particularly helpful. But when you think about the idea that 2 milligrams of buprenorphine sublingual delivered in a 24-hour period of time, more than half of the mu opioid receptors are available. That allows us to go direct conversion from one to the other. We'll talk about that more. So the consensus statement in our Webster study that I think is kind of the keystone is that when do we want to think about opioid management switching into buprenorphine therapy? Their final endpoint was we should use buprenorphine as first-line treatment instead of C4s or C2s, full stop. And I think that that's important to consider, and it really, I believe, informs how we should think about this, because it's really nice not to have to step into this in the first place. But certainly when you're developing lack of efficacy, tolerance, hyperalgesia, you're increasing your dose and your patient says, it's not working, I feel worse, or I don't feel better at all, we need to switch people over, right? Also, when you're concerned about, are they developing some sort of a problematic use pattern, is this the time to switch over? Obviously, switching sooner rather than later is in everybody's best interest, not just for decreasing the risk of an adverse effect or overdose, but also improving efficacy. There's also the advantage, if you have problems with how it's absorbed in the GI tract, buccal administration, sublingual administration bypasses all that, right? You can't swallow a buprenorphine pill and have it be effective. And then the other part about this, and I think where you'll really find benefit, is we've been switched over into short-acting agents, right? We don't want to use, in a chronic situation, we don't want to use long-acting agents because of the stacking effect on respiratory suppression. So if you give somebody 3 hydrocodone a day, you're well below MME recommendations. It might be helpful, but you're leaving their pain uncovered for at least half of the day, aren't you? And that's kind of the start of the dose escalation. Whereas if you can switch into buprenorphine and it's got that half-life and it's a very steady state, individuals, once they get to that level after about 5 to 7 days, they're going to be very comfortable throughout the day. They're going to have the same amount of medication in their system, and it just kind of puts the thinking about medication away, if that makes sense. So that's the part of this discussion that I have regarding the why of buprenorphine versus legacy opioids and typical opioids. And obviously the next part of the question is going into the how, and figuring out how to do that and getting comfortable with doing that is not quite as challenging as you might think. But as an echo group, we spent a lot of time trying to think about, how do we be practical? How do we give that information? So the next part of my discussion is really the first part of next week's discussion, which is microdose induction and how to induce these agents. So we can go one of two ways. We can go into a case discussion, and we can either answer questions about how to do this, or we can talk about some patients that I could bring forward. Or conversely, I could talk about the microdosing, and then we kind of try to put it all together, and then recover that ground next week with some case management. So I'm going to ask the group if they have a preference for that, because we can certainly go in either direction, and we want to make sure we're giving you what you want. Any ideas? Anybody want to vote on that? Will, can you give us some?
Sure. Yeah. Thank you. If anyone has a case now, that would be a good time. Is that fair to say, John? If anyone has a case, it could be a pain patient or other patient. Feel free to unmute, or you can also drop some questions in the chat if you have any questions for this first part of John's presentation.
Should we just?
Yeah, we got a question here. Can you briefly discuss what this means in the perioperative setting?
Yeah. Oh, excellent. So that's a big question. That is also in that study. So in the past, I'm sure everyone's familiar with the idea that now we got to worry about what to do perioperatively because they're on buprenorphine and will we precipitate withdrawal with opioids if somebody shows up in the ER or even if they have scheduled cases. Fundamentally, I'll go back a couple slides here. Whoops, one slide. Fundamentally, the recommendation is, and we see demonstrated improvement in pain relief if buprenorphine is continued in the perioperative period, full stop. All right. This is not just people who are being managed with opioids for chronic pain and on low doses. This includes individuals being managed with opioid use disorder. In other words, if somebody goes to the OR with buprenorphine on board and you're managing them postoperatively, you can co-administer legacy opioids. All right. This chart here, or the slide here, think about what that tells us. As long as the buprenorphine is on board first, the legacy opioids will be effective. They'll go in and they'll do what they need to with the remaining receptors that are not filled. So an individual can, a surgeon, right? They aren't going to want to think about this very much, but if you give somebody a total knee arthroplasty and they're on 8 milligrams a day of buprenorphine, and the surgeon says, I want to use oxycodone, what can I expect? You'll get efficacy. You probably get increased improvement in pain control than you would if you didn't have the buprenorphine on board, but you certainly will not get less. And the nice part about that is then the surgeons, I think what we're seeing is reduced use of opioids postoperatively in patients who come into the OR with buprenorphine on board. So the best answer is it's a non-issue. And now getting that information out is kind of important. It can change some of the, very specific dosing intraoperatively, but like we know in the opioid use disorder world, if somebody gets their hands on fentanyl, they can override the beneficial effects of buprenorphine. So we can do that. We can do that perioperatively as well in the OR, intraoperatively without difficulty. But unequivocally, postoperatively, patients do better when their buprenorphine is continued perioperatively. So all the when do I stop it and when do I restart it has been a tempest in a teapot probably, and we're trying to get that word out. Great question. Thank you for that.
We're getting a few questions in here. This is good. So let's see. I'm going to come back to Hemant's question. Holly Eckhart. I think maybe you answered Holly's question in the chat, John. She said she's a CNM here, and a patient who was in remission relapsed after a cesarean with opioid management in the hospital. How to use opioid? So how to use post-op instead of opioids? I think did you cover that?
Yeah. Well, not really.
No.
Right.
No, go ahead.
That's the additional benefit, right, of continuation, because you're forcing that patient at a time of great stress and trauma to make the decision to get back into their treatment if they're on buprenorphine for opioid use disorder, and when is it time to stop my postoperative opioids and go back into buprenorphine. That's a very easy setup for a problem, as an individual can have a difficult time with that as they're struggling through the anxiety of a postoperative management. But if you continue the buprenorphine, you don't face that, right? We just say use your buprenorphine, reduce it a little if you want to use more of the legacy opioids, but then just get right back into, just reduce or just discontinue the legacy opioids and move forward, and you reduce the risk of reactivation or relapse of their disease. Perfect question. Yeah.
Okay, so we've got a couple questions, and then I think we've got a case here too. So I'm going to go back to Hemant's. Hemant has two questions here.
All right.
First question: if the half-life is so long, what happens if a dose is missed?
Great question. So half-life of 35 hours. Really, what that tells us is that an individual takes, what do you take? 5 hours to reach steady state. So that's just a little under a week. And if an individual misses a dose or even a couple doses, the trough levels go down a little bit, but not a great deal. And the peak, and so that steady state is so comforting and helpful for patients, because if they're used to the idea that if I miss my one oxycodone, I'm going to know it in 2 hours, I'm going to feel terrible and what have you. And in this instance, they can go, I've had patients who went away for the weekend and like, I just forgot my medicine. And by Monday morning, I started to notice some effect. I tell people it's kind of like buprenorphine is really that ocean liner that's going to push us in the right direction and keep going. And you've been riding on a tugboat that a big wave knocks you aside and it doesn't get done. It does. The difficult part about that is you have to make accommodation for that with initiation, because it takes 5 half-lives to reach steady state for individuals. And what individuals will often do, and we'll do that as clinicians, will get too aggressive with onset, and so we'll push them into side effects, nausea and drowsiness and what have you, that are unnecessary. We need to start the medication and build it up over a few days and let them get into that therapeutic index without trying to way overshoot it in order to give them relief right away. So excellent question with that, because that's the benefit as well as the downside of buprenorphine, is that long acting, and the fact that it takes a bit to get going, but once it gets going, it's very steady. Thank you.
I'm going to keep going through. We've got a lot of good questions here in a case or two, it looks like. The second question from Mont is there a toxic and lethal dose for buprenorphine?
Well, yeah, you know what? We're never going to sit here and say there's not a lethal dose of an agent. You can do it. An individual can accomplish a lethal dose of that. It's challenging, and I think all the data shows us that individuals who have had fatal overdoses of buprenorphine almost always have significant impact from a combination of other drugs as well. And maybe, the implication is it's an intentional overdose. However, it's quite rare, and certainly much more rare with this medication than others. I'd ask Todd if he's on. I'd love to know if he would answer that differently.
Is there a lethal dose of buprenorphine? I suppose. I mean, but we don't think of it in those terms, right? I mean, it's kind of like, is there a lethal dose of maybe SSRI, like Zoloft or something? Well, yeah, yes, but usually even high doses and handfuls of it don't kill people. They put them into a kind of a serotonergic state that could create some problems. And the same mechanistically with buprenorphine, but it's not something that it's not high on the worry list compared to the traditional opiates, as Dr. Massey or John has already pointed out. So I don't think anybody's really ever explored what's the lethal dose. So there's been lots of people that have overdosed in case reports, and by far and away, if those people are, don't have any significant medical problems and they're not on other medicines, it tends not to result in someone dying. Even when someone takes a benzodiazepine with buprenorphine, it tends not to kill them, quite frankly. It used to be we worried about that, and then all of a sudden we realized, that's probably not an issue. With traditional mu agonists, that is a concern, but much larger concern than it is with buprenorphine. So I appreciate the nature of the question. I guess I would kind of summarize it in saying it's possible, but pretty unlikely. And we don't know the exact dose.
Perfect. Thanks.
Keep going through these questions here. From William Hay, what are the additional considerations of use in geriatric patients?
So I think it's a great drug for use in geriatric patients because of one, the reliable metabolism of it and the efficacy. You know, a lot of these individuals have OSA. They'll be sensitive to medications. And you know, what we'll see with a lot of these individuals on their legacy opioids, right, is that they can get efficacy with an opioid for a bit. I believe their central nervous system is less neuroplastic, and so they don't respond adversely to opioids quite as quickly, but they develop adverse effects, right? So they get nausea, they get drowsiness in particular, and what have you. And I do think that we can see that without question in the geriatric population, and we'll talk about this more next week, but really the challenge with buprenorphine, I believe, isn't that it's buprenorphine, it's that we have to think a little differently as we initiate it because of those pharmacokinetic properties, the slow acting, the tight binding. So what we'll do is we'll initiate too high a dose too quickly, and they'll get nauseated, and they'll say, I can't take that medication, I'm allergic to it because I'm nauseated, where they probably would have been nauseated because on their oxycodone or their hydrocodone if they weren't habituated to it, right? So they blame the molecule rather than the fact that we're switching over. So a lot of times nausea and drowsiness is what we'll see in geriatric patients in a slightly increased risk than our other patients, but it means we went too fast or too quick or too high. And so we failed them in their induction or switch over, their crossover. And so backing down and going slower. And we'll talk about that because I use a boatload of the generics at the higher doses, and I'll extend it out. Just give you one example. I had a patient just like this, a geriatric patient who I'm going to say was on maybe 45 milligrams of oxycodone. I can't remember the specifics. And she was elderly, had a lot of problems, lived on her own on a farm outside of town. Family was worried about her. We switched her into buprenorphine, and she didn't have money to pay for the branded agents. So we put her on buprenorphine 0.5 milligrams, which is a quarter strip of the 2 milligram generic. And I said, I want you to take one of these a day. And she came back a week later saying it makes me nauseated. We gave her some Zofran. That's going to be transient. She came back and she said, it's too much. And I get red when, we gave her a patch and it didn't work. It was 375 micrograms a day. So then what we did is we just switched her to a quarter strip every 36 hours, right? Really strange, or every 48 hours. But as to the last question, what happened is she reached steady state. She took a quarter strip of buprenorphine every other day, and she got to a steady state. Nausea went away, drowsiness went away, and she had superior pain relief than she was getting on high doses or moderately high doses of oxycodone. Happy as a clam. And oh, by the way, if you can write for an individual, I'm going to give you 15 strips of a medication that's $40 a month when they're used to paying, $90 a month on generic oxycodone. You've really done them some benefit. And so you can utilize the way that medicine's acting in a way that works for you rather than against you. I like that question a lot.
Okay, so we've got a couple of cases here and then a couple of questions. We'll try to get to all of these.
All right.
We may have to save some for next week, but I can save them and we can get to next week. So, okay, we'll go to Howard Edwards. He's got a case here. 45-year-old male with morbid obesity admitted to hospital for severe and lower extremity wounds. He also added some additional info here. The male is on palliative care because unsure if it will realistically cover from severity of wounds.
Yep.
He has a history of opioid abuse, titrated to methadone, 10 mg PO post-op for Q8 hours. Been on Bup in the past by pain specialists that hated buprenorphine, did not work for him. Has a history of had a gastric bypass, taking dilaudid liquid PRN with dressing changes. The dilaudid 2 milligram, about 4 extra doses per day of physical therapy and dressing changes, states the best it's ever been controlled with methadone dosing.
Yeah.
John,
Yeah,
John, this is Janet. I did a direct message to him. I'll just weigh in on this one.
yeah.
Yeah, in looking at the whole situation, the fact he's on palliative care, may not survive, all of those kinds of things, I think I just leave him on the methadone. You know, it's so there are a few people in my experience who did not tolerate buprenorphine, didn't think it worked. You know, there are all kinds of questions about were they taking it correctly? Were they this? Were they that? You know, is it sublingual? Did they really let it dissolve all the way? And there are all those questions. This patient you describe is clearly a very sick person. There are many health challenges. The methadone's working for him. I think I just leave him be with the methadone. What do you think, John?
It's interesting because I also got a direct message about this patient yesterday, and I I think that that's an acceptable answer for sure. I have to know a little bit more, but here's the thing: if he does have use disorder, then the opioid, the Dilaudid for breakthrough will never be enough, right? What you're asking him to say is, what's the right amount of cocaine that's going to make you feel like the right amount of cocaine? It means even though you're using Dilaudid to manage the wounds, what's going on is he's interacting with it differently because he's got that genotype. So he probably did hate the buprenorphine, and that's perfectly reasonable. But it wasn't the buprenorphine. It was probably the dosing and the way it was initiated. And I'm going to bet dollars to donuts that he was given a Belbuca. He was given a pain patient's version of buprenorphine. He needed an opioid use disorder version of buprenorphine. And now how do you have that discussion with him? Because he's in the hospital. He's probably at end of life. You don't need to make him feel like, hey, we're going to treat you differently. This is exactly where a microdose induction would work, because you could say, keep going with your legacy opioids. Let's sneak in a little baseline buprenorphine in the background so that Dilaudid isn't as necessary for your wound checks. And then just, to me, that the concept of this is when you teach your kids to ride a bike and they've got training wheels, you put the training wheels on and then you just slowly raise them up, right? Until they look up one day and they're like, oh my gosh, I'm not on the training wheels. That's what I would probably take as an approach, but I think yours is perfectly reasonable, Janet. But just recognize you're kind of treating opioid use disorder with methadone in a hospital, which you can do, but that's what you're doing, and you're going to need higher doses. I'm not disagreeing with you, Janet, but
Well, I hear you. I was just looking at the whole thing,
yeah, I get it.
sometimes I mean, there are probably all kinds of reasons. And, if he started to recover and looked like he was gonna make it, then I would really go through the effort of switching him from the methadone and doing the buprenorphine and forcing that issue. But again, I was just, it just
Great
seems a little
point.
more
No,
practical at this point. Yeah.
no, that you're right. It is more practical, and most importantly, you're not going to be criticized for whichever way you go. And we need to plant our flag on that hill. Whatever you do in that situation, is okay, because that's a complex. Those two problems are fighting each other, and we have to have a patient-centered model on that.
Okay, we've got 2 more questions in 4 minutes, so maybe we can squeeze these last 2 in before we end this morning. From Clinton Jones, 75-year-old vet with history of addiction, wants narcotics, and vet's home won't give it to him because of the history. What would you do in that case?
All right. Happens all the time. Here we are, right? I would say what your challenge there is that you have to redirect the patient's thinking and say, well, the VA is recommending the right thing, but for all the wrong reasons. In other words, you will do better on buprenorphine, irrespective of whether or not you had a problem with use disorder or opioid dependence. When you hear narcotic addiction, you can feel the stigma, right? And you can tell that somebody's setting themselves against this patient. What I'd say is, yep, that informs how we need to treat you to make you better, but we're going to make you more better than what you thought. And now you have a lot of ground to cover in order, basically motivational interviewing to get the patient to understand that you're on their side and you're going to do what they want, just in a better way. And it's not because the VA won't let you or the government will look at you wrong if you do it. It's that it's going to make you feel better. So the language that the VA has used for this patient is probably a big part of the problem, but the recommendations are, we can do both. Your pain will be better with an agent that they'll accept. And they do. Anyone answer that differently?
We've got one more question. If we can get to that one before we wrap up this morning, from Lath Hobbs. Says, I have a question regarding your practice when you inherit legacy opioid patients. How do you manage patients on high MME referred to your practice that do not want to switch to Buprenorphine?
Well, that's everyone, right? Everyone. Nobody comes into me saying, hey, I was sent to you with just enough Percocet to get to your office and I hope you switch. They hate that. And I believe that the DEA or CDC guidelines are very clear about this. We don't force taper. They don't want, it's wrong to force taper an individual, and your success is not going to be higher if you meet an individual and you start to come up with a better plan before you've got a strategic alliance. So the whole key here is how you listen to the patient and say, all right, we've got work to do to get you better. Let me hear how you're feeling. You use those motivational interviewing techniques to have the patient really tell for you why they're there, right? They're not doing well. That's why they were sent to you. So I think the right way to manage that is to say, all right, we'll take over your medications for now. We're going to manage them. We're going to do what we're doing, but I want you to listen to me later on, and I'm going to start talking to you about better ideas. And I'm an interventional guy, so I've got lots of fancy tools I can do for specific pain things, but I don't want to do those until I get a handle on the medication, because opioid hyperalgesia or opioid prescribing that's negative for a patient gets in the way of the benefit of all these high dollar things that we can do. So what I typically would recommend is you take that patient over, you manage it with them, you let them know that you're going to make them better, and then you bring it on at the pace that they can take. And then once they start to say, all right, I'm listening, what are you talking about? That's when you kind of move them into their understanding of this. You slide them into microdose induction, where you gradually bring them into this new medicine as you gradually bring the other one over, and they're like, I'll be darned, I'm 50% better. I'm feeling a lot better. Thanks. And then they say, now what? Right. But if you say, hey, look, if you don't do it this way, I'm going to fire you. Yeah, I don't take over patients with this. This is risky and what have you. Somebody else can do that. Or you have a problem. You have narcotic addiction. They're going to say, thanks, you're a jerk, and give me a 1 star and go off the other way. And I probably deserve it. So I think it's, and the training here, the reason we're here with this grant is that's what the CDC wants for us to do. They want for us to take care of patients in a way that's safe. They don't want us to force taper. They want us to know the risk, and they want us to know how to translate into better therapy. So that's what we're hoping to teach you. So that's just a fantastic question to end on.
All right. Yeah, we will have to end there with end of our hour. So for those of you looking to claim CME, I dropped a link in the chat to get that, just take that quick survey. I'll also be sending out an email here in the next couple of hours. And we hope to see you next 2 weeks from now. John's kind of got the second part of this training covering microinduction. So
the goal will be the practical aspects of what we've talked about today, I think, is the way to think of that. So thanks.
Okay, great. All right. Hope to see you in 2 weeks, and reach out to me with any questions or if there's anything our team can do to help. Thanks, everybody.